So we're going to wrap up now with a discussion on the phases of rehabilitation. And really, what I want to do here is talk about different ways to think about treatment. We'll look at a treatment or protocol approach, a phases approach, and a healing approach. And really, in reality, we're looking at an individual approach, right? We have our patient and we have the patient goals. We have the individual problems that we're addressing in those goals and the different causes associated with that. So our patient is going to have a unique rehabilitation experience, right? I love this saying from, with the end, we've got work to do. Right? And that's the reality of it. It's going to be an individualized approach. There is no cookie cutter rehabilitation aspect, and if there is, it's probably less than ideal with that. We use evidence and best clinical expertise judgment to make our decisions, but really we need to be understanding all of these different approaches in order to be making our unique decision for our client at that point in time. So we will start with the treatment approach. And the treatment approach, right, or sometimes I refer to it as a protocol approach, and some of these names I made up with that, really focuses on an injury-specific treatment plan. Right? You get a protocol from the doctor. After this ACL injury, with that, I want you to do X, Y, and Z for 4 weeks, this sorts of things. And so it's a protocol approach. You also, the reason I call it a treatment approach is because you have these indications for therapeutic modalities, right? The idea that if X, right, then this modality can affect Y, right? So the idea that if I have swelling, there are modalities that are indicated to reduce swelling with that. Same sort of thing with specific exercises for specific injuries, right? We have exercises that we tend to like with specific injuries, and that makes sense because we've had good results with that, and it's, what we've considered the best for that injury associated with that. And this can also be based on evidence, right? If we have evidence associated with that a specific injury, that a strengthening program has been helpful, then we should utilize that, right? And so the overarching thing though in these is it's very time-based, and we know that the healing time can be different. And that's the major downfall to the treatment or protocol approach. That it's based off of time in the treatment plan opposed to maybe what we're seeing in the clinic. In order to address that a little bit, it's been recommended that you use some sort of a phase approach where we have progressive phases. And so the idea here is that you have a goal for each phase, right? Each phase builds on the next, but then once the criteria for a phase is met, then you can have progress to the next phase. And so this helps us then have the fact that really, this is just a model here with that. It helps to make sure that we incorporate all the different components associated with therapy and allows for some efficiencies to occur. Now, there are all sorts of different designs for phases of rehab depending on who you're reading. We'll kind of look at some of these. Most of these overlap. They just name and the number of them. So I don't ever like to say, like the third phase of rehab, because the third phase of rehab for hurdle is restore range of motion. Here in Prentice, it's neuromuscular control, and here it's late rehabilitation. So we'll go through this, not that one's better than the next, but the idea that all of them provide some form of reference to what we can be doing to help choose the treatment modalities that would be most effective for our patient. So the hurdle aspect here comes into play where you have the physical examination, kind of the acute stage here with controlling swelling, controlling pain, and restoring integrity of the injured tissue, right? So these are different phases that occur at the same time. Next, we are focusing on range of motion and volitional control of contraction, the idea of muscle activation. Once we have good muscle activation, we can restore strength and endurance as well as reflex patterns, our proprioceptive and neuromuscular control. Then complex and functional movements, and then finally return to functional activity. So he has a pyramid type approach where you build off of the next, and all of these build off of the next and go through there. So in the 7+ component, there are different phases there. The first phase in this one is immediate care, where the goal is controlling swelling and pain, right? In controlling swelling, right? This is the price, rice, pick something in there. The whole debate comes, and we are having that in our semester project with that. But the idea is we do want to control swelling, right? Swelling is different from inflammation, right? This here is detrimental to healing regardless, right? Because that is excessive in nature, and it makes it so even though there is more fluid in the area, which theoretically would mean there's more nutrients, more macrophages, all that sort of stuff, it's so diluted in such a large area that the concentration isn't adequate to allow for healing to occur. And so when we get into this and in controlling swelling, what we really need to get into is venous and lymphatic drainage, because that's how the swelling is going to be eliminated. All right, so how you can go do about that, we talked a little bit about compression wraps and changing the hydrostatic pressure associated with that. Ice bags with the idea to then decrease the amount of blood flow to that. You notice here is even a different protocol, 45 minutes, right? And then an hour and a half off, or so as much as possible for that 48-hour period. Elevation, again, changing that hydrostatic pressure as much as possible. Pain obviously is very real, and we will spend a lot of time talking about pain later on in the course as well. But if nothing else with pain, think about the fact that pain makes strengthening and flexibility more difficult. And so if we have an exacerbation of pain, right, due to either an increasing extent of the injury, right, the patient's response to pain is just as much, or the circumstances, we're going to have a decrease. Remember that aspect where we have function, we have a painful episode, and so function decreases, and then we have to build up. We want to avoid that stair-stepping mechanism. One way to do that is to make sure we are focusing on controlling pain and minimizing pain to allow for maximum therapeutic intervention. There's a big difference between just trying to control pain and doing nothing else, and trying to control pain for the purpose of increasing and fixing the problem long-term through therapeutic exercise. If all we're doing for somebody with back pain is hooking them up to heat and stimulation to decrease their pain and then sending them on their way, well, it makes sense that they're going to have to do that forever and ever, because we're not addressing the actual cause of their pain through therapeutic exercise. Core stability as a goal goes in there. That's always important with that. That dynamic stabilization. And when you think of core, right, you really need to think of it as the lumbopelvic hip complex, right? The hips are just as much a part of that to control right through there. And so there are all sorts of different exercises you can do that, but that's a legitimate goal for all of them. Reestablishing neuromuscular control and muscle activation. Sometimes this gets used interchangeably with proprioception, right? Proprioception, by definition, is just the ability to sense the position in space. So this is really joint reposition sense, the idea that if I ask you to hold your arm, and so if this is your body, put your arm at this angle and then bring it back down and ask you to repeat that angle. Can you really know where your arm is in space with that? And that's associated with mechanoreceptors in the muscles, joint, and the skin in particular. This is where, taping has an effect on neuromuscular control because it increases the amount of deformity of the skin, thereby increasing mechanoreceptor sensitivity and increasing proprioception. Kinesthesia then is the ability to sense that motion. And so the reality is we need to be able to sense where the joint is in space. We need to be able to sense the motion, but then we need to be able to activate that muscle to get that force controlled with that. And we'll see that more when we get into stability and balance here in the next component. But muscle activation, the idea, and we will talk about muscle inhibition and maybe the isometrics we do early on, not so much for strengthening, but to increase that muscle activation, increase the amount of motor units we're able to recruit when needed. And that then leads to controlling stability and balance. And that's not just stability, balance with regards to the lower extremity, but this idea of stability as well, where we have these learned reflexes that we can avoid the extremes of range of motion and contract those muscles to stop the extreme range of motion. And one of the best ways to do that is through closed kinetic chain activities. Another goal that's common there, right, is restoring range of motion. And when we get into this idea, loss of range of motion can come from a number of different factors. And from that, we have to decide what is actually causing that. If it's a muscle length issue, like the actual change in the muscle length, right, this is much more chronic than a neural tension or a contracture of, this is connective tissue, but you can also have an increase in muscular tone in there. And so when you're looking at these sorts of things, you have to figure out what the cause is. The muscle length, if the muscle is just too short because maybe they had a growth spurt late in life, so their bones grew and their muscles were never able to really catch up. The people with like chronically tight hamstrings because they just have no range of motion there. We need to try to increase the overall muscle length. Whereas somebody that maybe just had an acute hamstring strain but didn't have range of motion to begin with, their range of motion is due to a spasm or contracture of the muscle there. And so we need to promote relaxation with that. And you can do that, right, with your thermal modalities, different aspects like there. But if you're trying to increase mechanical or muscle length, you need mechanical modalities with there. Same components then with the connective tissue and the contracture of connective tissue or excessive scarring in there, right? Or abnormal arthrokinematic motions, often secondary to that. Then you need joint mobilizations to restore the arthrokinematic motion, or that roll, spin, and glide compared to just the osteokinematic motion. Restoring strength, endurance, and power. Obviously, these are very common and fairly well understood in our world. Usually you start with singular plane, move to functional, isometrics right early on, progressive resistance, possibly isokinetic, and then finally for power, right, plyometric activities as well. Another phase that is often neglected is maintaining our cardiorespiratory fitness. Right, the idea that there are still a lot of things that our patients can do, and they've trained a lot, in order to try to maintain this cardiorespiratory fitness. There is something to be said about, like actual sport activity shape, but you can mimic a lot of that in alternative therapies. Aqua jogging is one of my personal favorites, right? Because you put them in a belt or whatever, and I can have them do, repeated. I can have them do long distance stuff, or I can have them do sprint stuff as well. If I have a basketball player, maybe I have them do, 15-second sprints with 15 seconds off, and just have them do that over and over and over again in a non-weight bearing situation. So it's great for somebody with an ankle sprain. We can keep that fitness up. And we've even seen in long distance athletes that elliptical and aqua jogging has just as good effect on maintaining their fitness level with that as normal training. So you can get actual gains through this as well, because the cardiorespiratory system, remember, is mostly about the heart and lungs distributing oxygen to working muscles. It's not specific about which working muscles are most important. So you can be doing everything from an upper body ergometer and a hard arm bike workout, right? And as long as you're getting the heart rate up into the zones you want with the recovery you want, you can actually see the gains that you can directly associate to effectiveness afterwards. All right, the last phases are the functional progression and functional testing. With that, I talked about the stability and balance within there, but the stabilization phase, right, where we're trying to correct any deficits in structural integrity with muscle control and stability. Right, you have a strength phase and a power phase associated with that, where now we're basically taking the same components that we did in rehab, but we are breaking it down into those sport components. And this is one of the reasons that it's good to be at practice. You can use the same language that they have, know the drills, be able to break it down with that. So that's one advantage that athletic trainers usually have, is we're very knowledgeable of the sport-specific demands that our patients participate in. Right, and then lastly, we have functional testing. The idea now that eventually we will want to get to a point where our drills and practice is similar to what they're going to be doing in their and sport-specific drills to test their ability for functional approach. The last phases approach that we will look at is simply what I've termed the healing approach. We basically take the phases of healing and turn them into phases of rehabilitation, where we have an early phase that corresponds with the acute phase of healing, the intermediate phase, which is the proliferation phase, and then finally the late phase, which is the maturation phase. And you can see an overview here where we have the characteristics associated with that phase of healing, right? And then we're going to turn that into a phase of rehabilitation, right? Where an early rehabilitation corresponds with the inflammatory or acute phase of healing. We're going to have the short-term goals associated with that level of healing. So controlling primary inflammation, specifically the swelling, secondary inflammation as well. Try to facilitate the rate and quality of tissue repair. So you can see how this is slightly different. You could take the same aspect, right? The facilitate the rate of quality of tissue repair. This is where before we were talking about early range of motion, right, as a phase. So they all are talking about the same thing. They're just using slightly different language. Same thing here, minimize muscle strength loss and muscle atrophy, right? This is our muscle activation component. Preserve the somatosensory proprioceptive input, same thing there, right? And then you can see how we're maintaining optimal levels of fitness throughout. This has a nice progression in there, where at this point, in order to leave the early rehabilitation, one of the big things, right, is we have to be able to know that the tissue can support increasing level of tensile stresses, so the protective devices should be there. And based on our knowledge of the timelines of healing that we talked about at the beginning, know that we've increased tensile strength to allow for us to progress now to the immediate rehabilitation component in there. So same things, you'll see the vast majority of these in that middle component: normal joint mobility, functional progression properties of the scar tissue, general flexibility, right, strength and strength balances and endurance, our proprioceptive and neuromuscular control, gait patterns, physical fitness. You'll see continue all the way through. The progression then ends at this point where now we have restoration of both the structural and the functional properties of the affected tissue. So now we can get into more sport-related activities that will be associated with the late rehabilitation phase. So now we are trying to maximize the restoration of both tensile strength as well as the plasticity, or not elastic, because we don't want these things, or not all tissue is elastic in its ability to stretch, but the plasticity in its ability to accept that tensile strength without stretching or while returning to normal. We have the optimal restoration of all of our aspects there, and then our establishment of normal sport activity as well as sport fitness parameters. Some of the different interventions then that we can be looking at in the acute phase, right? We want to really be focusing on pain throughout this entire process, as we talked about. In the acute phase, we have pain associated with rest and passive and active motion. In the repair phase, we might have pain associated with movement, right? And in remodeling, there might be pain after movement resisted as we're recovering. But any pain outside of this, and we're still trying to minimize the amount of pain, and that's our main component associated within the acute phase. Whereas when we get into the repair phase, you can see here are the goals associated with that, the same progressions associated with that. In this case, we're only looking at modalities probably to control and allow for pain-free activity, opposed to trying to actually decrease acute pain. If we have acute pain, it's probably because either we are stressing the tissue too much or we haven't really made it to the repair phase yet as well. Once we get in the maturation phase, pain control should no longer be required at all. We're really trying to eliminate any tissue restrictions, and because we're replacing that type 3 collagen with type 1 collagen, so we want to make sure we're getting the most alignment as possible, right? Decreasing the potential for adhesions or contractures, right, where we have scar tissue where we don't want that. So you might be using modalities in that situation to minimize scarring or adhesion. And modalities here, I'm going back to like therapeutic modalities, your more electrical sort of stuff with their opposed to rehabilitation. And then you might need to do, especially with overuse exercises or overuse injuries, some pain, swelling, stiffness management. And so there still is a role for that. Obviously, in the maturation phase, there is this idea of a rest re-injury component, right? Where if we get that stair-step component that we saw with that, we're having actually new injuries each time here, and so might go through an acute phase associated with that we need to go back in time out of the maturation phase back into more of acute and repair phase associated with that. Right. Also, at that point in time with that, we have to remember that we're not, as we continue with that, if we don't have normal functional level as far as conditioning, we have the potential for injury to occur as well. So that's why if we have general deconditioning, we have that increased risk of injury. So it's important that we're maintaining that throughout. With delayed and failed tissue healing, right, this occurs in different tissues associated with different aspects. We see this a lot in tendons, right, articular tissue, and some bones, right, where we don't have good blood flow or whatever associated with that, and so we can't get healing. This is where, you know, sometimes we have to use steroids just to stop the inflammatory process, because we get stuck in that chronic inflammation, right? And chronic inflammation is different than repeated acute inflammation, right? This is repeated acute inflammation here. Chronic inflammation is when we never move out of the inflammatory phase into the repair phase with that. And so we can use some, you know, different electrical, acoustical, or light energy to help improve our wound healing with that. And you can think of that as well, right, in delayed non-union fractures, how we might be using, in this case, you know, bone stimulator, light, low intensity pulsed ultrasound. That's what a bone stimulator is. To, you know, throughout the proliferation and into the maturation phase to maximize the amount of healing that occurs. So anyway, those are the different approaches then that we can think about. Again, try not to think about using one approach over the other, but combining all of this information into making a unique treatment approach for your patient at that time.